Hello, everyone. Welcome to today's webinar on onychomycosis, diagnosis and treatment with our speakers, Professor Avner Shemer and Dr. Maame Idun. Our hosts today are myself, Parisa Molakazemi, and Sarah Anwar. We're here on behalf of the GLODERM Trainee Committee. A little bit about us, if this is your first time joining us, the GLODERM Training Committee is part of the ILDS, International League of Dermatological Societies, and also a part of GLODERM, the Global Health Dermatology Training Program, where our mission is to promote knowledge equity by enhancing access to dermatology education worldwide. And our initiatives are promoting educational webinars like the one you are joining today with high quality learning opportunities, networking and collaboration with trainees worldwide in dermatology. And we also have a podcast series that addresses challenges in global health dermatology. So thank you for joining us today. Just some housekeeping slides and meeting etiquette. Your audio will be muted during this webinar and your camera will be turned off. Please submit any questions in the chat or Q&A function, and Sarah will be able to monitor that throughout the webinar. And we will be sharing further information about the GLODERM program in the chat function as well, so keep an eye out for that. So I want to have, I'm happy to have the pleasure to announce our speakers for today. So we have first Professor Avner Shemer. He is a specialist in skin and venereal diseases and an associate clinical professor in the Department of Dermatology and Venerology at Tel Aviv University. He is affiliated as a retired senior physician with the Department of Dermatology at Chaim Sheba Medical Center. He serves as the head of the Israel Council of Dermatomycology and Nail Disorders and acts as an advisor on mycological disorders to several pharmaceutical companies. He has authored over 100 publications and delivered numerous lectures in basic research and clinical dermatology, with particular expertise in fungal and nail disorders. We also have Dr. Maame Idun, who is a general practitioner from Ghana with 4 years of clinical experience in chronic disease management. Her interests include dermatologic care access and education, chronic inflammatory skin diseases such as psoriasis, and the use of digital health tools to improve early diagnosis and long-term care delivery. She is currently pursuing an MBA and MPH at Johns Hopkins, where she explores how emerging technologies, data-driven decision-making, and community-centered design can strengthen equitable healthcare delivery. So we're very happy to have them here today. Thank you so much for joining us. You can follow us on social media to learn more about any upcoming events or webinars, programs, and more. At GLODERM Alliance on Twitter, Facebook, Instagram, and YouTube. And thank you to our supporters, CeraVe, Care for All, and the Ellis Foundation. So with that, I'm going to pass this on to Professor Avner to share his screen and give his lecture for today's webinar.
Okay, good evening, everybody. We're going to talk about onychomycosis, the diagnosis and the treatment. So let's go started. So onychomycosis is a fungal infection of the nail unit, most common affecting the toenails, but 20 times more often than the involvement of the fingernails. We know the rule of 2 feet, 1 hand disease, which means that usually we see both 2 feet get involved with the tinnitus and onychomycosis, and sometimes we can see the involvement of 1 hand, rarely 2 hands, but usually 1 hand, and sometimes we can see the 1 hand, the tinea manum, there is the involvement of 1 or 2 or more fingernails. So it's called 2 feet, 1 hand disease. It is caused by fungi such as dermatophyte yeast or non-dermatophyte molds, and typically leads to change in the nail color, thickness, shape, and texture of the nail plate. The nail may become discolored, yellow, white, or brown, brittle, thickened, or crumbly, and in advanced cases may separate from the nail bed, which is called onycholysis. In the vast majority of cases, all affected nails are infected by the same pathogen, usually the same pathogen. Only in rare cases, there is several or two or more different pathogens could be in the same nail or different nails. Okay, so now let's move to the fungus kingdom. We can see there is about 400,000 different species of fungi, but only about 150 are pathogenic to human or animals. All fungi are eukaryotes, which means Golgi complex, mitochondrium, and heliocandian cell wall, cell membrane. So this is the principle of the fungus. The cell wall is rich in chitin, heliocandians, and the cell membrane, which is the layer from the inner part of the cell wall, is rich in ergosterol. And I stress this point because the medications that acts against the fungi are preventing the cell membrane to become completed by killing the several parts of the ergosterol, which is very important part of the cell membrane. Without the ergosterol, the cell membrane cannot exist and cannot, its function doesn't work so good. So we need the ergosterol. So the different medications affect the ergosterol to become not that good to fact as a function of the cell membrane.
Okay.
So we talk about the fungal kingdom. So there's around 400,000 different species, but only 150 are pathogenic to human and animals. All fungi eukaryotes, and the cell wall is rich in chitin, and the cell membrane is rich in ergosterol, which is the most important part of the fungus unit, because we need to we know that we have many different medications working on the ergosterol to create good membrane. So once we cannot create good ergosterol, and as a result not good enough the cell membrane, the fungal is die gradually. So onychomycosis, the prevalence of clinical and the clinical burden is onychomycosis are about between 3 to 30% of the population. Onychomycosis is the most prevalent disease of the toenail. About 50% of the nail disorders are related to other nail disorders. Part of this group has also onychomycosis. So in general, about 50% of nail disorders are onychomycosis, and the other 50% are related to other nail disorders. But there is a small group that are combined disorders. So let's move to the clinical classification of onychomycosis. There are 7 subtypes of clinical patterns of onychomycosis. The first, which is the most common, is DLSO. It is distal and lateral subungual onychomycosis. The second one is superficial white onychomycosis. The third is endonyx onychomycosis. The fourth is proximal subungual onychomycosis. The fifth is mixed pattern. And the fifth and the sixth is total dystrophic onychomycosis. And 7 is a secondary onychomycosis. Let's move to the next slide, and then we can see that regarding the causes of onychomycosis, so dermatophytes are between 70 to 75% of the causes, yeast 15 to 20%, non-dermatophyte mold the same percentages, and mixed pathogens between 1 to 5%. So regarding the prevalence of the clinical classification of the toenail onychomycosis, so distal and lateral subungual onychomycosis are about 75 to 85%, which is the most common. Superficial type between 10 to 15%, proximal subungual between 2 to 5%, and all the rest, which are endonyx, mixed pattern, total dystrophic primary or secondary onychomycosis, between 5 to 10%. Now we can see the most common clinical type of onychomycosis, which is distal and lateral subungual onychomycosis. We can see the clinical picture. We can see the involvement of the toenail in the distal part and the lateral parts, thickened and yellow, gray-yellow. And the most common pathogens are Trichophyton rubrum and Trichophyton integrophytes, but it could be other fungi, of course. And we can see here in the middle picture, we can see the pathogenesis. There is no onychomycosis without tinea pedis because the nail, the involved nail got the fungus from beneath the nail, from the distal part of the toe, going up to the inner part of the nail plate, and then there is involvement of the disease caused onychomycosis. Here we can see the superficial white onychomycosis. The most pathogen is Trichophyton integrophytes. We know that we have several types of Trichophyton integrophytes, and this kind of onychomycosis, the fungus are located in the superficial part of the nail plate. In this case, for example, if we take the sample beneath the nail, we shouldn't find the fungus because it's located on top of the nail. And I'm going back here. And in this case, if we take the samples from the superficial part of the nail plate, we shouldn't reveal any fungus because it's located beneath the nail. So it is very important when we have to do a fungal smear and direct microscopy and culture. Once we take the smear, the debris, we should take it from the precise location where the fungus is located. It is very, very important. We can see many times the results of the fungal culture and fungal direct microscopy are negative, not because they are negative, because the sample was taken from the incorrect location. Okay, so this is the superficial white onychomycosis. It's called superficial white onychomycosis, but there is in several countries superficial black onychomycosis. It is very rare. You see the endonyx onychomycosis. This is a good sample regarding the samples. In this case, if we take the samples beneath the nail, we shouldn't reveal any fungus. If we take the sample from the superficial part of the nail plate, we shouldn't reveal any fungus, because in this case, the fungus located in the intermediate part of the nail, as you can see in the right picture. So in this case, we have to cut with scissors the nail and to send it to PCR or to culture. It is very rare clinical type of onychomycosis, but it is very important point to stress regarding the fungal debris when you take for the laboratory. Here we can see the proximal subungual onychomycosis, the fungus located in the proximal part of the nail. If there is also paronychia, pain, should think about Candida onychomycosis. But if there is no, or non-dermatophyte molds, such as Scoriolopsis brevicualis or and the Sonella torloidea. And if there is no paronychia and only this clinical picture, usually it's T. rubrum or T. mentagrophytes, as we can see in this picture. Here we can see the mixed pattern of onychomycosis. We talk about superficial white onychomycosis, we talk about distal and lateral, endonyx onychomycosis, and proximal onychomycosis. But sometimes several clinical types can come together and make the mixed pattern onychomycosis, as you can see here. Here we can see on the left side, we can see here proximal subungual onychomycosis and distal and lateral subungual onychomycosis. Here we can see distal and lateral subungual onychomycosis and endonyx onychomycosis. Here we can see distal and lateral and located in the lateral side. And this is stubborn condition, for example, the lateral onychomycosis. Okay, here we can see the total dystrophic onychomycosis. In this stage of onychomycosis, it can come from any clinical type of onychomycosis. It's called the end stage of onychomycosis. All the nail get involved, and there is a thickened nail and yellow or gray color, and usually we cannot achieve complete cure in this stage of onychomycosis because there is a damage for the nail bed and the nail matrix. Here we can see the secondary onychomycosis. For example, this patient has psoriasis, and once there is psoriasis, and we know that there is a chance to have more often onychomycosis in psoriatic nails. So here we can see onychomycosis and psoriasis together. So the onychomycosis is secondary to the psoriatic nails. Here we can see, let's move to the when and why should we take nail debris for the laboratory. First, we shouldn't take fungal debris or nail debris if the clinical presentation is not related to onychomycosis. Let's give you several samples. For example, we know pitting of psoriasis, right? So in pitting of psoriasis, it's not one of the clinical subtypes of onychomycosis. So in this case, we shouldn't take a fungal smear because it's not related. Or for example, if we see a traumatized nail which had a trauma, and then the nail become thick and deformed, maybe this nail has also onychomycosis, but it's not the case to be treated. So if we have a clinical presentation that's suitable for onychomycosis, so we should take the samples from the location where is the fungus exists. For example, if it's a superficial, so we take from the superficial part. If it's distal and lateral, so we take from beneath the nail. If it's endonyx, we have to cut the nail. It's depend where is the fungal located, because many times, very often, we see negative results, which is not correct, not because there is no fungus, just because the sample was taken from the incorrect location. So to scrap the debris under or above the nail with a small curate at the border between the normal and the diseased nail. I did the study many years ago in London when I took the samples from the distal part of the nail and it was negative. Then I re-debris again, I took it again and again. The more deep I took the debris, the most common I got the positive results. Here we can see several nail disorders which are not onychomycosis. And in this case, for example, we shouldn't take a sample for the laboratory because whatever the result should be, we cannot achieve any improvement in these cases. Here we can see the deformed nail. Here we can see the callus and the deformed nail because of the shoes. Here onychomycosis because of the nail lacquer. So let's move to the mycology part of our talk. So if you want to see if there is a fungal yes or no, so we take a direct microscopy. What is direct microscopy? We take the smear beneath the nail or above the nail, depends where is the fungal supposed to be located. And then we take a potassium hydroxide, 10% or 20% or 30%. And then we leave it for about half an hour up to 1 hour. And then we take a look at the direct microscopy. And then we look to the microscopy. And then we can see in positive cases, we can see the hyphae. You can see the hyphae here and here. It's with septed hyphae or not septed hyphae. And then we know that we have a fungus, but we don't know the type of the fungus in this case because it's all called direct microscopy. But if you want to know what is the type of the fungus, we have to send the debris, a new debris, to the laboratory for culture, and then we put it in dish, saborodextrose agar dish, and then to be incubated in 28 degrees up to 30 degrees Celsius for about 21 up to 1 month. And then when we take it out from the incubator, we take some samples from the Petri dish and look at the microscope, and then we can see the macroconidia and the microconidia and the combination shape of the microconidia and the macro and microconidia. We can know what is the type of the fungus. So in the laboratory, when we took the samples from the dish from here and put it under the microscope, we can see the microconidia, which is the big ones, and we have 3 different types of microconidia. That's all. We have microsporum or trichophyton or epidermophyton. And the microconidia, we have many types of microconidia, and the combination between the macroconidia and the microconidia will give us the type of the fungus. For example, here we can see the Trichophyton tonsurans. We can see this is the microconidia and this is the macroconidia. Here in the case of Trichophyton mentagrophytes, here we can see the macroconidia, the big bodies here, and the small bodies here are the microconidia. So the combination and the organization of the macroconidia and the microconidia will give us the type of the fungus we're talking about. So what are the predisposing factors for onychomycosis? There is a genetic predisposition of to have onychomycosis, yes or no. There is a family history. The age, the more the age, the more common the onychomycosis. Medical conditions such as diabetes mellitus, HIV infection, immunosuppression by taking steroids, for example. Tinea pedis, I told you before, there is no onychomycosis without tinea pedis. Peripheral artery disease, physical and environmental factors such as obesity, low hygiene, non-ventilated shoes, etc. Here we can see the 50% in the color, the 50% of toenail onychomycosis, and the other 50% are another nail disorders. And there is a combination part which is located here, such as psoriasis, nail traumas, onycholysis, onychomatosis, onychorexis, trichotillomania, etc., etc. So in general, we have onychomycosis, pure onychomycosis, only onychomycosis. We have nail disorders which are not onychomycosis, but we have a combined disorders, which is nail disorders with onychomycosis. And in this case, I want to stress something very important. If you do a fungal smear and culture and you see fungus, for example, and you give the treatment in case of combined disorders, the antifungal medication should treat the fungal part, but not the other part of the nail disorders. So in this case, we shouldn't expect to get a complete cure. So I wrote here I wrote this combination area usually decrease the cure rate of onychomycosis, because the rest should be the basic disorder of the nail, and we might think that there is still onychomycosis, but it's not. So combined disorder is not rare at all. Complete cure for pure onychomycosis with oral treatment is about 40 to 70%. And the complete cure rate for combined nail disorders is low comparing to pure onychomycosis. Let's move to the treatment of onychomycosis. There is an oral treatment and topical treatment, pharmaceutical product, medical and devices, and combined oral and topical treatment. Combination therapy with an oral and topical therapy will increase the cure rate. I mean, if you use only systemic treatment or topical treatment, which is not indicated for onychomycosis in general, topical treatment is not the gold standard of treating onychomycosis. But, and it's a big but, if you give the systemic treatment, such as terbinafine or itraconazole, combined with topical treatment, we increase the cure rate. So let's move to the different medication we have for onychomycosis, the triazoles, such as itraconazole, fluconazole, posaconazole, voriconazole, and there is some and several and others medication which is not in the practice use. And from the allylamines, we have the terbinafine, which is the only one that we have from the allylamine group. So let's see in this slide together the azoles in the left side. So the azoles, different azoles like posaconazole, itraconazole, fluconazole, ravuconazole. And we know that the azoles, this group of medications, blockade the 14-alpha demethylase, and it's blockade the creating of the ergosterol. And because it's blockade the creating of the ergosterol, it's called fungistatic action. On the other hand, terbinafine also affect the 14-alpha demethylase enzyme and prevent creating the ergosterol. So the terbinafine has an arm that's fungistatic, but the major arm of the terbinafine is fungicidial action. Why? Because it's blockade the squalene epoxidase enzyme. Once the squalene epoxidase enzyme is blocked, so there is an accumulation of the squalene. There is an accumulation of the squalene, and the squalene is toxic for the fungal cell. Say it again. When we blockade the squalene, there is an accumulation. When we blockade the enzyme squalene epoxidase, there is accumulation of squalene, and the accumulation of squalene is toxic for the fungal cell. So this is the major arm of terbinafine, which is fungicidial action. So in general, we can say that terbinafine is much stronger and much, we can see better results with terbinafine comparing to the azole. But, and it's a big but, sometimes there are cases, not rare cases, that terbinafine doesn't work on these snails and the azoles do, and vice versa. But if we compare in general the terbinafine to the azoles, for example, itraconazole, the terbinafine has better results, but not in all cases. Here we can see the the treatment of onychomycosis. In the left side, we can see the different medications such as itraconazole, fluconazole, posaconazole, voriconazole, and the administration goes with food or with empty stomach. For example, itraconazole here in this case, itraconazole must be taken with food, but fluconazole doesn't matter. Posaconazole, you can take it with food or without food. And voriconazole, it's necessary to take it on empty stomach. Let's move to the dosage. So the itraconazole, we can take it on two different regimens. The most common regimen called the pulse therapy, which is 400 milligrams of itraconazole, 200 milligrams in the morning, 200 milligrams in the evening, and every capsule is 100 milligrams. So we take 2 in the morning, 2 capsules in the evening, which is 400 a day for 1 week. Then after 3 weeks off. So, and then another course of 1 week itraconazole, 200 milligrams in the morning after meal, 200 milligrams in the evening after meal for 1 week. So we do it in 3 or 4 cycles like this. And there is another regimen we can use the itraconazole, is about 200 milligrams a day, 2 together in the morning after meal or in the evening, continuously therapy for 3 up to 4 months. So if we make the calculation, by the way, the results are about the same, the clinical cure rate, if we compare the pulse therapy, which is 1 week on, 3 weeks off, 1 week on, 3 weeks off, 4 cycles, for example, comparing to 200 milligrams continuously therapy for 4 months, the cure rate are about the same. But if we make the mathematical calculation, we can see that in the pulse therapy, we use a half dosage in totally in the pulse regimen, comparing to the continuously therapy. So usually in onychomycosis, we use the pulse therapy, but in tinea corporis, or in the body, diffuse, severe tinea corporis, we don't use the pulse therapy, we use the continuously therapy, which means 200 milligrams a day after meal, once a day for several months. Because the mechanism of the pulse therapy is very important, because the medication are concentrate in the nail matrix because it's lipophilic, and the drug remain in the nail matrix and continue to act up to 9 months after the cessation of the itraconazole. So in the skin, it's disappear after several weeks, 2 or 3 weeks at the max. Let's move to fluconazole. Fluconazole, we have to drink water after we take the fluconazole. So the dosage is between 150 up to 300 milligrams a week. Usually it's indicated for tinea corporis or onychomycosis. There are several countries that fluconazole are not permitted for onychomycosis, but for the tinea corporis, yes. Posaconazole is 300 milligrams once daily for 3 to 4 months. And the voriconazole, there is a loading dose of 200 milligrams twice a day for the first day, and then after 200 milligrams once a day for 3 up to 4 months. And here we see the monitoring of liver function test, or renal function, CBC, and while in the medication of posaconazole and voriconazole, we have to monitoring the ECG or EKG because sometimes there is a distribution in the LT in the EKG. So we have to take care of these two medications, the posaconazole and voriconazole. And here we can see also the side effect. So we have to take a look carefully for each drug and take care of our patients. So let's move to terbinafine. Terbinafine, we can take it with food or without food. It's allylamine group, 200 milligrams once a day for 3 up to 4 months. We have to test the monitoring liver function test, renal function, and CBC. And here we can see also the side effects, which are rare but exist. So now let's move to the topical treatment. We can see here the nail cure for onychomycosis, amorolfine, cyclopyroxalamine, efinaconazole, dioconazole, and other not medication therapy, but device. And here we can see the topical antifungal medications such as bifonazole, clotrimazole, terbinafine, and cyclopyroxalamine. And we remember that the combined treatment between the systemic treatment and the topical treatment will give us better results than systemic treatment alone. Now let's move to several clinical pictures of onychomycosis which were treated correctly with the systemic treatment and topical treatment. Here in the left picture, we can see the onychomycosis, and the right side, after 3 months we can see the improvement. Here, after 10 months, we can see before and after. We can see the nail that was thickened and in different colors. And then after 10 months, we can see beautiful results. Pay attention for the fifth toenail here, for example. You see the fifth toenail here and here? There is improvement, but not complete cure. You remember we talked about combined disorders? That there is, because of the shoes and pressure of the lateral side of the shoes to this fifth toenail caused to the toenail to be thickened with or without fungus. In this case, there was a fungus, but the problem is there is not only fungus. That's why we can see here that the nail is still thickened, not because of the fungus, but because of the pressure of the shoes on the lateral side of the fifth toenail. We usually see this phenomenon in ladies, which like to wear the tight shoes. Also occur in men, but usually in women. Look at this, before the treatment and after treatment. In case you give the patient systemic treatment and you don't see any improvement or mild improvement, you should move another medication. For example, if you started with terbinafine, you can move to itraconazole, but not after 1 week, not after 2 weeks, after 2 months at least, because after 2 months, you might see any improvement. And so I asked my patient to take a photo of the nails before the treatment and every month, and then we can compare the results after 2 months. And then we should decide if we go to another medication, yes or no.
Yes, we have questions, but I think we're going to have Dr. Maame present first and then do questions at the end. And
All right.
for time purposes. So Dr. Maame, if you want to share your screen.
Is my screen visible?
Yes, looks perfect on my end.
Okay. Hi, everyone. So today I'm taking you through a case presentation to bring to life what we've just heard from Professor Shemer. So this is a case of a 47-year-old male who's been a farmer for 20 years, generally healthy, had an appendectomy 22 years ago prior to being seen, and has no regular medication use or no known drug allergies. So clinical signs here, patient has had onychomycosis for 15 years. And as expected, this was seen with tinea pedis as well for the same duration. To confirm the diagnosis, direct microscopy from the left hallux and the sole was done, and this was positive for fungal elements. So on my left, you see a direct potassium hydroxide wet mount showing branching septate fungal hyphae. And then on the right, you see a lactophenol cotton blue preparation highlighting the septate fungal hyphae, confirming that there's fungus involved in this case. On culture, the culture for the specimen is positive for T. rubrum, and both plain and then SDA with cyclohexamide and chloramphenicol was done. Other labs, including a complete blood count and liver function test, was in the normal range. And so treatment was initiated. Final diagnosis of dermatophyte, onychomycosis, and tinea pedis made. And systemic treatment with terbinafine 250 milligram once daily for 3 consecutive months was initiated. After 3 months of this treatment, mild to moderate improvement was seen, and an additional month of terbinafine was administered. At this point, all toenails were almost cured clinically except the fourth left toenail. And this was 10 months after initiation of the treatment. So I'm going to go ahead and show some pictures of how the nails looked. So this was before treatment. On the left, you're able to see the thickening of the nail bed at the distal portion. And after treatment, generally almost all the toenails are cured except the fourth left one here. So this shows you that the fourth left toenail is still thickened and discolored at the distal part. And because of this, remicrological analysis was done on the fourth nail. Direct microscopy initially was negative. Culture was also negative. And this prompted some curating and drilling from both the proximal and distal part of the left toenail. And we just learned in the previous lecture that the location where the sample is taken from is critical, because you might get false negative results on the first try. So reanalysis was done on the drilled sample. And this time, direct microscopy was positive for fungal elements. A culture with cyclohexamide and chloramphenicol was negative, but plain SDA was positive for Scopulopius breviculus. And this is a non-dermatophyte. And now we know that there was also a non-dermatophyte in play here, as well as a dermatophyte that had been previously cured. In further lab analysis, we see septate hydra with chains of arthrochonidia on direct microscopy, and then this is the plain SDA. So 3 different mycological analyses were performed to confirm the diagnosis here. And then PCR was done as well to confirm the diagnosis, which was positive for Scopulariopus breviculus. Treatment here was done with systemic itraconazole. So here we switched from terbinafine to pulse itra, where itraconazole was given 200 milligram twice daily for a week every month and repeated for 3 cycles. 6 months after cessation of treatment, marked improvement was noted. And 9 months after cessation of treatment, patient was completely cured, both clinically and mycologically. So here we see before treatment with the fourth toenail still thickened, and after treatment, the fourth toenail back to normal. So the main takeaways here is the fact that there's a possibility of having 2 different types of fungi in the same patient, and in this case, in the same nail. Negative standard mycological analysis in the first instance does not always mean that no fungi exist. It's important to make sure that you are taking the sample from the right location to ensure that no fungi really exist. And yes, just to reiterate the importance of using the correct method and the right location for mycological analysis. Relevant fungal media should be done in cases of suspicion of non-dermatophyte molds. And this case demonstrates the superiority of itraconazole compared to terbinafine. In this case, we used pulse itra, which is about 50% less of the entire dosage the patient would have. And this brings me to the end of the case presentation. Thank you.
Great. Thank you so much, Dr. Maame. I'm going to pass this now to Sarah to go through some questions that we have for Professor Avner and Dr. Maame that came in throughout the webinar.
Our first question asks, what do you recommend for diagnosing and treating onychomycosis in low-resource countries?
In where? There's a problem in these cases. So topical treatment depending. There are two parameters. First, what kind of medication you have. The other one is what the clinical type of onychomycosis and the severity of the onychomycosis. The more the severity of the onychomycosis, you need to have the systemic treatment. And because topical treatment works only in mild cases for a long time.
Thank you. And then how long can someone stay on systemic antifungal treatment if there's no improvement within the recommended time frame?
2 months. 2 months, it's enough time to decide if you move to another medication.
And next, someone noted there's an increasing issue of drug-resistant dermatophytes and asked if you could elaborate on the problem within onychomycosis.
There is a resistance of terbinafine for in the last 20 years. And now we say that we have about up to 20% of the T rubrum is resistant for terbinafine, which was not occurred before the 2005. There was no resistant, but now we see up to 20% resistant for terbinafine, and also for itraconazole, but in high percentage for terbinafine.
Thank you to both of the presenters, and thank you for answering the questions. That is all we have time for today.
Thank you very much.
Thank you again, Dr. Maame, Professor Avner, and everyone who joined today. That will conclude our webinar on onychomycosis for today. Thank you.
Thank you very much.
Thank you.